And we're here. Good afternoon, everybody. Welcome to our live stream. Good afternoon, Chief Bessler. Now that we're all out of our meetings, we can talk.
It's all the same people I was just in a meeting with.
I know, that's what I was looking at.
We could have all just stayed on the
Okay.
Zoom call.
Yeah. I hope more people than our meeting are here. Our meeting had more viewers, actually. I think we had 66 in our meeting today.
Excellent. Okay, thank you everybody for joining. Can you guys hear me okay? Well, that's because you're not that important, Shane.
Ooh.
Jasmine, can you hear me okay?
I can hear you.
Okay, great. All right, so thanks everybody for joining. Sorry we missed last week. It just, Tuesdays have become very, very busy days.
We're hoping you're more friendly than the people were in the BCC meeting.
Yeah. I guess we'll just start with the regular update, and then I'm gonna just take questions, I think, this week. We're working up some relatively minor changes as things increase, but I don't want to get ahead of the announcements on those. So what I'll do, sorry, go ahead.
So what he's saying is make sure you tune in next week because there will be changes coming.
They're going to come before next week. You guys need to be paying attention at the end of this week. This is not a time where we can hold your hand. So when you see stuff come out as a Target Solutions assignment or from your EMS coordinator, you need to pay attention.
I'm glad that you said that today and not me. So yes, I meant next week, have your questions ready for live stream and tune in. That's what where I was going with that.
Thank you. All right, so here's what it looks like. And I think it's pretty obvious to see that for the last 3 or 4 weeks, we're on an exponential growth. You've heard some people asking about, is it just because we're testing more? And the answer is no, it's not all just because we're testing more. We look at something called percent positivity to control for how many tests we're doing. And our percent positivity is now over 10%. We're over 13%, 13.2 as of a day or two ago. And you can see that just a few weeks ago, we were at 1.3%. So that's everybody who's getting a nasal swab of what we call a PCR test. Over 13% of them are positive in the last week or two. And that is significantly increased. So yes, we're testing more, but we are also seeing an increased rate of infection. And with a positivity rate of 13%, we are clearly headed in the wrong direction. You can see this is the exponential rise in cases. This is a rolling average, a 14-day rolling average. Unfortunately, the curve is most assuredly not flat right now. This is a regional dashboard for the Clearwater, St. Pete, Tampa area, but this same trend is being seen in lots of places. On a similar vein, let me get to the right window here. Don't want to put that one. Sorry, took a couple clicks to get there. On a similar vein, you can see that as our cases went up exponentially, we now begin to see an increase in number of folks hospitalized altogether. Today or yesterday, we are over 300 hospitalized. We've never been that high before. It wasn't but a week ago that we were 200 or so, and a week before that we were 100 or so. So clearly things are rising. The number of folks in the ICUs is also significantly high, with about a quarter of those 300 patients hospitalized being in the ICU. So the expected course of this is that you see a significant uptick in cases. Yes, they're largely younger, healthier people, but not exclusively. And yes, most of those folks do fairly well, but not all of them. And so we are seeing that as the cases have risen exponentially in the community, you cannot attribute that to one piece of the community and not expect the rest of the community to be affected. We are all connected, and particularly when it comes to a respiratory virus, there's no stopping this going from one segment of the community to another. So as would be expected after an exponential growth in cases, we are now seeing a week or two behind that, a significant increase in hospitalizations, and we're into a couple weeks into that now. Now we're beginning to see, just over the last week, a significant increase in the number of folks in the ICU. And I would expect that, unfortunately, next week we're going to see more deaths. The way this disease course goes, you get exposed, and after a week or two, you become infected and symptomatic. And maybe your symptoms are mild for a week, and then they get more severe and you get hospitalized. And maybe you're in the hospital for a couple of days, and then you get even worse and you go to the ICU, and then maybe you're in the ICU for a week or two, and either you recover or unfortunately you die. And so it's no big surprise to see that, with cases spiking a couple of weeks ago, that we're now starting to see the spike in hospitalizations and the spike in ICU and the coming likely spike in deaths. So it's not a very pretty picture. It is, as I said, the curve is most assuredly not flat right now. And all of the things that we talked about before in terms of why it's important to flatten the curve still apply. And none of that has changed. And so we are now beginning to see the hospitalizations increase. The hospitals are trending upward in terms of their occupancy. There is a significant number of hospitals that are beginning to feel full. And as you may have seen on the status board, lots of hospitals have asked to be on COVID divert. That whole process is being reviewed right now to see if we can do it better or different or more sustainably. But we are clearly losing the battle right now as a community. We are all in this together. One of the cardiothoracic surgeons from one of our hospitals that happens to be looking after some of the sickest of these patients who are on ECMO machines asked me to relay that that we are a community. We are all in this together. I know it is. That it is frustrating and painful and annoying to have to socially distance. I know it is all of those same things to wear a mask. I know it is all of those other things to have to deal with this on an ongoing basis. But I think it's quite clear that we are losing the battle right now, and we as a community need to do everything we can to try to turn the tide here. A friend of mine sent me this, and this is a joke, but there's always a little nugget of truth and humor. This is why we want to flatten the curve. July 1st is right around the corner, and we will have our new interns in the hospital. It's funny because it's true, kind of. My younger sister is a physical medicine and rehab, or PM&R, resident, and she has spent the last 3 months of her life working in a COVID rehab hospital up in New York. And there are people who are extending outside their normal lanes within the world of medicine as the hospitals become more stressed, and that's a true thing. And what we don't want to see is us get to the level where people who are having STEMIs or strokes or traumas or whatever can't get the care they need in a timely fashion because the hospitals are too overwhelmed. I think it's worth noting that there have been various reports, but something in the neighborhood of approaching 700 healthcare workers that have died in the United States from COVID. And that is an incredible tragedy. and a reality for us since we're also healthcare workers. I think it's also worth noting that the number of cases among our group of first responders has increased more than exponentially, if that's even possible, over the last few weeks. And so this is a reality that we're now dealing with. We have significant numbers of folks who are either out sick or out on quarantine. And it is at the point of probably beginning to impact certainly staffing patterns, hopefully not operations too much yet, but it's clearly a risk. So I think that's where we are in terms of context. The other things I want to share with you today is that, again, this is a very new disease, and we know less about it than we would like, and we need to continue learning about it, and we do continue learning every day. I said to somebody way back in the beginning of March when this first started, I said, as a frontline healthcare worker, I have a high suspicion that at some point I will get this virus. I hope not, but I think it's a reasonable expectation that I may at some point. And I told them I would like to not be in the first wave, not be in the second wave, and hopefully be in the 5th or 6th or 10th wave when we know a heck of a lot more about this virus and how to treat it and how to keep people from getting sick. Because everything we're learning continues to be scary. So there was a lot of reporting early on about your blood type, and I think somebody actually mentioned that in the comments already, whether your blood type could impact your risk of developing severe infection. And some of that data came out of China, and it was kind of early. There's new data coming out that actually supports that. So congratulations, if you're type A blood like I am, you are inherently at higher risk of having severe infection. So awesome. We've got that going for us, which is great for any of you Caddyshack fans out there. Come on, nobody's old enough to get that movie quote, I know. We don't know why yet. We think it may have something to do with some genes that are next door to the blood type gene on the chromosome, but we don't really know yet. We do know that there's something going on there. The discussion about NSAIDs, Advil, things like that, whether they make things worse or not, remains out there. Thank you, Chief Megan, for the Gunga La Gunga. That's perfect. At least somebody got it. Okay, so we got a couple of Caddyshack fans in there. Good. I'm showing my age right now. We don't know so much. There's still this controversy as to whether NSAIDs help or hurt. There's still a lot of discussion about things like ACE inhibitors and angiotensin receptor blockers. Most people feel like there's not enough evidence to point one way or the other, and all the major associations have said, well, if you're on them, don't stop, and if you're not taking them, don't start taking them, particularly for this. But there's just so much we don't know. First we thought steroids are bad. Now maybe we think steroids are good in certain people. So we're learning a lot. And we talked even with Dr. Antevi about the pediatric inflammatory syndromes that look like Kawasaki's that we're learning about. But there's other stuff coming out now. There's a new, we talked about it a little bit before, I think, but there's a lot of things coming out about long-term neurologic consequences of having this infection, even if you are young and healthy and did pretty well with your infection. There's a group of people who are calling themselves the long haulers. You can Google that and find articles about it or websites about it. But they are folks who are weeks and months after having COVID experiencing neurologic issues with fatigue and weakness. There was a paper published earlier this week or last week about the neuropsychological effects of becoming infected with the virus. Particularly as they apply to not just older people, but younger people. We've heard from folks like Amal Mattu about the cardiac consequences. We've had direct invasion of the heart muscle, so myocarditis from the virus. We've heard of encephalopathies and meningitis type stuff. We've obviously got the lung things. That's sort of one of the primaries. We've heard it could be in the GI tract. It can do lots of things. And that's why I said, I really hope to not get this thing in any of the first couple of rounds, because I'd like us to know a lot more about it. And so I think it's a good time now, particularly with the demographic of new cases shifting closer to a lot of the folks who are our frontline responders, to reemphasize the fact that just because you are young and healthy and in good shape doesn't mean that you will come through this thing unscathed. I'm hearing lots of reports about people who are very, very athletic, who go through this infection and have their pulmonary capacity or their cardiovascular capacity just decimated for months, and we don't know if that's going to be permanent yet. So I do want people to realize that we have never been at higher risk or had more transmission in our community than we currently do. And just because you're young and healthy, I'm just, please do not take this thing lightly. We don't know enough about this new virus to be able to say that you'll just be fine. You don't have to look far in the news to realize that there's a lot of people saying contradictory things, and people say contradictory things based on opinion when there's not enough data to know. So, pay attention to the fact that, this week we thought one medicine worked. Next week we think a different medicine worked. And what does that tell you? That tells you it's not a disease I want to have yet, because we don't really know what works or doesn't work. So if you can protect yourself from this thing, whether it's at work by doing the PPE, having a high index of suspicion, going through the pain and suffering and sweating and uncomfortableness of wearing the PPE and doing the right thing, if you can protect yourself, whether you're back in the fire station or off duty or wherever, I want to emphasize again that we really, really, really need to be looking out for each other during this and looking out for ourselves, because we want to minimize this thing as much as we can as a community. And with a respiratory virus, we are all in this together. There's no keeping it in one segment of the population. The kid who went out to the bar is going to bring it home to grandma who had a kidney transplant, or their sister that works in a nursing home, and immediately it just spreads. So masks when and where you can. Now, not everybody can wear a mask, and you can't wear it in every situation, but if you can, do it. If it's something that you can do, great, do it. If it's something that you can do to minimize your interactions with other people, do it. I get that it's annoying, and I get that it's uncomfortable and all of that, but we're in this together, and there are literally people dying in our hospitals. There are healthcare workers getting infected and having severe disease and dying, trying to keep those people alive. And there are your friends and coworkers who are getting sick or off work because they've had an exposure, and their family members then at home. So, please do what you can to help this spread in our community, not just in your professional life, but in your personal life, because at 13% positivity plus, we are in a bad way right now as a community. We are leading the way. There are multiple states out there right now that say, if you have gone to Florida, you need to be quarantined for 2 weeks before you can come back and get back to work or go back to your normal routine. I was on a call with some folks earlier today, and multiple states were talking about how they now consider us down here in Florida, along with Texas and Arizona, really the hot spots for this in the country. And so I get that we're all tired and we've been doing it for a while, but this is the time. It's never been scarier than right now for us. We are beginning to be impacted in our workforce by lots of people having to be off. The hospitals have the same challenges, and the hospitals are beginning to get full, and we all know what happens if the hospitals become overwhelmed. So please do your part. I would also say, try to avoid some of the more heated discussions on this, just do what you can do. If everybody does that and treats each other with a little bit of kindness and a little bit of courteousness and respect, I think we'll do much better as a community. So I think I'll stop there and start trying to answer some of the comments and questions in the chat. Okay, so how significant is the blood type in relation to the severity of symptoms? I don't know the full answer to that yet. The data is still somewhat sparse, but there does now seem to be a significant correlation. Remember, correlation is not the same as causation. We don't know the mechanism yet. Somebody once postulated it has something to do with microtubules in the cells for you bio nerds out there, but really, I don't think we truly know the answer to that yet. Pinellas County begins the curve, no surprise there. Yeah, Florida man, right? Strikes again. Mike asked about complete COVID bypass. Again, we're working up alternate strategies on that right now. We hope to have a better plan to you guys here within the next couple of days that might include some different ways of doing that, but we're working on it. I don't have a full answer for you that yet. Dr. Lozano is on and notes that the fallacy of attributing more cases to testing is evident. And the logical conclusion, if that were true, would be that if we test less, the number of admissions would go down, and that is clearly false. Chief Bessler suggests that we send our medics to the hospital to get intubation practice. No, that's about the highest risk exposure we could give to our medics, but thank you, Chief. I think we'll leave that to the, I actually have to tell you, when it comes to that right now in the hospitals, in many cases, we're not actually letting our residents intubate. The attendings are doing it to try and minimize the exposure to our residents. So I've actually intubated more people myself than I have in a while over the last few weeks because of that. So what else? It's kind of funny that you say that, Mike, about the heavy stuff coming down. He's making a Caddyshack reference, but if that graph is any indication, the heavy stuff could be a week or two from now, and it could really be a miserable month for us going forward here. So I would say brace yourselves. If there's no reason to expect that curve's going to change right now. I mean, hopefully some of the things we did at the end of last week or what the governor did in terms of the bars may help, but I'm not confident that that's enough. So buckle up. Chief Jameson notes we have a good number of people off. Yes, please try to protect yourself. Jacob notes that, yeah, the care of these patients is very individualized. You know, some folks have, you know, mild or no symptoms at all, and so they don't need much of much, but then how do you sort out the ones who need much more than that or are going to have more severe disease? I don't think we fully understand that yet, and it's been a challenge for me seeing patients in the ER to have there's no decision rule like you have for a pneumonia or a DVT or, you know, a heart score for your chest pain risk stratification to decide which one of these patients needs to come in or go out. And any guidance that we do have is shifting on a nearly weekly basis. So it has been very difficult to know for sure which patients are going to fly at home and which patients need to come into the hospital. And it's also been difficult to know which patients are going to stick with just pulmonary kind of things and which patients are going to get other types of organ systems involved. So yeah, Jacob, it's very difficult to have a overarching treatment pathway or strategy when you have so much changing in terms of our knowledge and so many different presentations for this virus.
So real quick, while we're talking about that, something that has been asked many times in this chat that has been coming up consistently, I think that we can just emphasize and clarify on this. If you have a patient that has a history of COPD or CHF and they're having shortness of breath, that does not mean that they are not a COVID patient. You would still need to wear PPE for those calls. So I know that out there, I mean, you're looking at the history of the patient, and I know it's hot, and I know that people do not want to be in that hot PPE all the time, but we need to protect each other. And it's really important to know that we don't know who's positive. And there's so many people out there who have had exposures. Just because they have that history does not mean we don't need to dress out on those calls.
Yeah, thank you. At this point, with the level of transmission in the community, you need to be really cautious and just really honestly, the best thing we could all do as a community is assume all of us are contagious and assume everybody you come in contact with is contagious. And we would probably do the best we could that way. But please don't become complacent about when to take full precautions. You know, the baseline precautions are great and, you know, I think will help us and have helped us significantly, but please don't become complacent. So somebody just texted me something that I have to share because it's amazing. And it says, the medic says, it's so hot wearing PPE in the summer. To which the response is, it's air conditioned in the ICU. Just saying. So I get that it's uncomfortable. I really do. But we've got to take precautions here. So a question on testing. Oh, wait, before that, research showing a benefit to gargling with hydrogen peroxide to combat COVID. I feel like that's right up there with the drinking bleach thing we heard from somebody. So no, I haven't seen anything related to that, sir. Testing continues to be an issue. Yes, I know it's an issue for the entire country. I'm very hopeful that, and I believe something will be announced here in the next day or two that will help us significantly on the testing front in our community. Michael says, rent out the trop for positive patients. You joke, but there was a call this afternoon about, do we need to start spinning up a field hospital right here in Pinellas? So we are, you know, we are looking at those types of things right now. We're back in that mode like we were 2-3 months ago when we were talking about all of those options. I'm glad you enjoy my joke, Peggy. If you keep it up, I'm gonna play some music you love too. Okay, so Dusty asked a question and I need to address this because there's an idea that getting a test can somehow return you to work if you've had an exposure. And I need to go through that because I know a lot of people have had concerns about that or have heard that. And that is simply not true. I'm going to try to pull up a graphic here to illustrate what I'm talking about. So give me just a second. Okay, so let me share this up. All right, hopefully you guys can see this article. So one of the issues that we've struggled with as a country, and I think it's very clear that we have struggled with this issue as a country and continue to, is how to diagnose somebody and whether or not we can rule it in or out. And this is an article, it's an opinion piece, but it's actually a very well crafted and pulls together a lot of data into a way that's easily to be interpreted. And so this is what I really want to show you is this graphic right here. And so in the time before you become symptomatic, a test really doesn't help you too much. And by test, I mean a PCR test. That's the nasal swab, what's called an RNA or nucleic acid amplification test, which is not the same thing as an antigen test, which is a different test. But the chances of you testing positive are fairly low up until right before you become symptomatic. And then you tend to stay positive for some period of time after that. And eventually that positivity goes off. But we've had folks who are out here and are still intermittently getting positive tests. And that's one of the reasons why the 2 negative tests before you return to work kind of thing doesn't really work. Now that's a little bit different from here, which is the actual live virus coming out of you, which is probably done by about a week and a half or 2 weeks after your infection. And so just because you can still find some viral debris or RNA on the nucleic acid amplification doesn't mean that you're actually shedding live virus and contagious. So that's one thing. The other thing is, this is your exposure period or your quarantine period before symptoms, right? So if you got exposed here, it can take 2 weeks for symptoms to develop. And if you get tested anywhere in this first week, it's pretty well useless unless you've already become sick. And if you get tested anywhere in this second week, it still shouldn't actually prevent you or relieve you of having to finish out the 2-week quarantine. So most of what the health department's been recommending to us right now is that if you have a true exposure, you are quarantined for 2 weeks, and we'll test you somewhere around day 12 to try and make sure that you're not an asymptomatic infection who could spread it to other people who would then become symptomatic. So that's kind of the strategy we're looking at right now. Another issue is the antibodies. The antibodies don't actually turn positive and get detectable in most people till somewhere around week 3, somewhere in the neighborhood of 21 days. And so I don't want anybody to think that a antibody test, that's what's sometimes also called serology tests or called IgG or IgM. I don't want anybody to think that one of those tests is a legitimate way to exclude acute infection in somebody, because it's not. That's for after the fact. Did you have it and not know it, or did you have it and have you developed some kind of immunity, hopefully? So antibody tests, definitely not for acute infection. PCR tests, okay for the acute infection, but don't really alleviate the need to do your quarantine. And then the new test is the antigen tests. And those tests are very specific. So if it's positive, it probably is, but their sensitivity is not great, somewhere in the 75%, between 70 and 80%, which means that 2 to 3 out of 10 people that have it will still test negative. And so that's not a great screening tool either if you're trying to, eliminate positives from causing exposures. So the tests are a difficult subject, and it's something we've struggled with as a country, nationally and locally. And there's so many different kinds and so many different brands that it's very difficult to sort through all this stuff and to know what's a reasonable way of using or interpreting a test. So I would strongly encourage you, if you have questions about testing, ask somebody that has a little bit more background in it, or do your homework before you actually decide to make a decision based on a test. If you have specific questions on tests, I can try to answer them here, or you can email me. If you have specific questions about how to return somebody to work, I would suggest strongly that you get in touch with one of the epidemiologists from the health department who can walk you through that in a very reasonable way. So let me stop there and see what questions there are on testing. And thank you for bringing that up, because testing is a big issue right now. Okay. So I don't see any other tests. Yeah, Chief, let me just try and stick it in the comments and see if everybody can have it right from the comments. I know I can do that on Zoom. Let me try that on here. Oops, no, it didn't work. Yeah, Chief, just send, if you pop me an email, I'll reply with it in the comments so I don't forget, please. Okay, so let's see what else we got. Any news on reinfection? Okay, that's a great question, Mike. And we believe that the antibodies that you could see on that curve are protective for at least a period of time. Previous SARS infections, the protection was at least a year or two. We don't know that for sure right now. There are studies currently going to evaluate that. So stand by on that one. If you've had it, I think you probably have some immunity, assuming you mounted a normal immune response. But I don't think that you can assume that you're home free and good at that point. So That's also actually one of the challenges in creating a vaccine to this virus. So stand by on that one, Michael. I don't think we have the total answer on that yet. We tend to think that there's some protection, but I don't think that we have that ironclad yet. So please still be cautious and wait on that one. Okay, let's see. There's another one in here that says, are we getting to a point of considering out-of-state transports for COVID, needing longer-term care? No, we haven't gone out of state. We've gone lots of other places a couple hours away to facilities that can hold the COVID positive patients safely. But we have not gone out of state to the best of my knowledge, and we certainly hope not to, because doing a long distance transfer with a COVID patient is extremely resource intensive. And for those of you who have done it, you can attest to just how exhausting that is. Dusty, okay, maybe I didn't answer your question, Dusty. Referring more to those who may call out due to other issues such as a headache or food poisoning, but not be able to return until they get, yeah, so that is a legitimate use of a test to clear somebody back to work. If you have a symptom and you're not sure if that symptom is COVID, to get a check to make sure that it's not before you come back. I would say you still have to stay out while you're sick, but if you've recovered already and want to make sure that you can come back, that's a reasonable use of that test. And as I mentioned, I believe there's going to be an announcement, hopefully today or tomorrow, which I'm not going to get ahead of, but I believe it's coming, that may help significantly with our testing ability here. Okay, great. So Mike, Dr. Lozano was answering some of the questions about the mouth rinse. That reminds me of medical school when we were doing jaw fracture surgeries and the nurse would brush the patient's teeth with iodine or betadine. Gnarly. Let's see. Yes, it's true, Chief Bessler. If you give platelets or blood, you will get your blood tested. I don't know the turnaround time on that, though. Shane asks, have we seen any big upticks of this affecting the pediatric population, or still very broad range for this disease? So yeah, it's certainly shifting younger, but I still don't think we have a ton in the young kids. I don't know whether that's because they're asymptomatic and not getting tested, or whether they're truly not getting infected. I do know that our pediatric units are not immune from the uptick in cases, though. So I don't have a real great answer for you on that yet, Shane. But as I said before, in a respiratory virus, there's no such thing as one segment of the population getting it and it not spreading to other segments of the population. This is one of those times where, whether we like it or not, we're all in this together. Okay, question on how far out is going to category red or condition red in the pandemic plan? And my answer would be, I hope we're still a little bit of ways from condition red. If we go to red, we are altering the clinical status pretty significantly, as you all have seen in those clinical treatment guidelines that go along with it. And so we're trying very hard not to get to that point and to use all of our mitigation strategies. I think a reasonable analysis right now is that we have been wounded and we are bleeding, but we are in compensated shock right now. We have not gotten to decompensated shock, and we certainly haven't gotten to irreversible shock. And I think if we get to decompensated shock, then we're talking about category red. And if we get to irreversible shock, then I think we're talking about category black. But I still think that you guys are doing an amazing job of preserving the standard of care in the community. The biggest issue is flow of COVID patients. Our other patient flows haven't really been impacted much yet. So I think we're okay on category yellow for now. Excuse me. All right. So some people are saying one blood with a 2-day turnaround. That's fantastic. All right. I think that's all the questions I've seen so far, but keep them coming. We'll try to answer a few more. As I mentioned earlier, there will very likely be a medical control directive going on Thursday that will alter a few things, some of which I think will make a bunch of you guys really happy in terms of how we do things. So please keep your heads up for that. I know we're going into a holiday weekend, but I think there's consensus that we need to make a few changes before we go into the holiday, given what we're seeing in terms of volume. So please pay attention to what's coming out in the next few days. I do think there'll be some changes that you all will be happy about. Dusty, I think that's one of the things you're probably going to see some new guidance on in the next day or two. Part of what I'm referring to. All right, what else do you guys got? Peg, what kind of music you want to hear while we wait? Oh, Chris says, we've been told there are no more N95s. Does the county still have any? So yes, when you say the county, I'm not sure if you mean the county as a whole or EMS, but we do have a substantial number of N95s at EMS, which we feel like we will probably need over the next few months. We will be continuing to try to balance our use of N95s and full face respirators to keep us in a situation where nobody goes without protection for as long as possible, anticipating that we need to look towards being able to continue this level of PPE for at least 6 to 9 months. If you think about how many N95s we use in a day, or would use in a day if we went to N95s on every patient, those numbers are fairly astronomical. And while we do have a very substantial stockpile currently, we feel like we're in a position to keep you guys safe for months and months and months. We also do realize that we need to be prepared to continue this level of PPE for 6 to 12 months. And I know nobody wants to hear that, and I know that sounds incredibly onerous, but short of a vaccine, that's probably where we're at. And by the way, some of you guys probably remember going through some of this, not to this extent, obviously, but some of this with Ebola a couple of years ago. And how's this for a headline on CNN today? That kind of stinks, huh? So they're not saying that that's coming to us quite yet or anything like that. But one of the things that we probably do need to take away from this whole experience is that we need to be ready to deal with infectious patients on an ongoing basis. Okay. Julie says, I think there needs to be caution stating every patient is a COVID patient because there has been confusion and problems with holding back treatments. Yeah, so what I mean by that, Julie, is that I want people to consider whether any patient could be a COVID patient and act accordingly in terms of doing a full appropriate assessment and protecting yourself. And I'm even more talking about out in the community, whether you're at the grocery store or wherever you are, to try to take as much precautions as you can to keep yourself and other people safe. And then hopefully that answers your question.
I think that came up when we were talking about the CHF COPD thing earlier. Just we're talking about taking the right precautions and wearing the right PPE.
Right. And Julia, I guess also we are sort of treating everybody as though they're infectious by the fact that we're in baseline PPE. That's sort of what I mean. So Dusty says, is there a plan in place if a hurricane was to happen here? Yeah. So EOC and everybody are working hard on that. there are contingency plans being worked up. I think you would see a lot less folks in shelters, if at all possible, in terms of the number of folks that are in those communal living situations. I think also they've increased the square footage allocated by person in the shelters, so they're having more shelters able to be stood up, and they're exploring potential options for even testing people on the way into the shelter, although that's very difficult as well. So it is something that's actively being worked through, Dusty, but at a level from the state all the way on down. But I don't think that I can answer all of those questions yet. So the question is, any chance that the stay-at-home refusal protocol for potential COVID patients could go live without the system going to category 8? Yeah, I think it's possible that we could decide that the hospitals are so full that we need to implement something like that, but we have not yet, and you will know loud and clear when we do. So stand by for that.
A lot of new information coming out in Target Solutions. Just keep your eyes out for that.
Okay, anything else?
3:45.
I think I got them all. All right, well, thank you guys for tuning in. And, you know I laid out a bunch of stuff and made a little bit of a plea there to keep yourself safe. Okay, wait, we got a couple more coming in. Lusher, what did you say? So that's a fairly politically charged question, Lusher, and why don't I give you a call when we're done and you can explain to me why you think that's the case. And I'm happy to talk through it with you, but rather than get into a whole big debate, which I've already sat through many hours of on the Board of County Commissioners meetings, maybe we'll just talk one-on-one. CFR is saying they can't get any N95s from the county. Is the county distributing them at all to the fire departments right now? I can't tell you the exact numbers that are going out the door to the fire departments, but no, it's not. There's not a ban on any FD use of N95s as far as I know. But as I mentioned, Chris, we are actively managing what kind of PPE people are using so that our limited supplies will last us as long as we can, and so we don't get down to not having an appropriate level of PPE for folks.
And different departments have different rules for what PPE you're allowed to wear, but the baseline is the same for everybody. I know some departments are allowed to wear N95s and others are not.
Okay, so I see what you're saying, Julie. And yeah, so remember that nothing in the standard of care has changed. We've adjusted some things when caring for a COVID specific patient or a patient that we know or have high suspicion is a COVID patient. We've adjusted a few things as are on that placard, but nothing has changed with the standard of care and the assessment or treatment expected for any patient in the system. And so I do get it. I know it. I know when you're seeing patients and you're in all the PPE, it's easy to skip over things that you might normally do. It's easy to have tunnel vision. And, you know, it's difficult to do, but that doesn't change what our responsibility to each patient is to do the very best assessment and treatment that we can.
In yellow, we discussed the hypoxic drive is higher in these patients. So if your patient needs treatment, regardless if they're a COVID patient or not, they're going to be receiving that treatment. You're just going to make sure you do a more thorough assessment of those respiratory patients and, you know, weigh out the treatments at that point. I don't think any treatment should be changing though. They should still be getting everything they need if they need it.
Yeah, let me say that a different way. just because the oxygen saturation goal says 85% instead of 94%, doesn't mean we'll settle for 85% if we can get it higher. It means that if the 85 is the best you can get before you need to actually go ahead and actively manage that airway. Maybe that, I don't know if that's a clearer way of saying it or not, but
there shouldn't be any treatments that are really being withheld. I mean, if you're
right, there's nothing that's prohibited or says don't do in that thing except for maybe the steroids. So I see there's a couple other trickling in here. Michael, we've had some COVID upgrades because the patient was in isolation at the ALF, even though they had multiple negative tests. Upgraded on Sunstar interfacility transports. Yeah, that has to do with the EMD codes, and we are actually actively looking at those right now to see if there's a way that we could siphon some of those off. We also do, frankly, have people calling and saying things that may or may not be true in order to get the response that they want. And that's an unfortunate fact, but it's something that is happening. So that is one of the things we're looking at, Michael. Jacob said it a great way. He said the patient care hasn't changed, the level of protection goes up with those treatments. And I think that's part of the reason why we want to stay away from category red just as long as we can, because that patient care does change much more once we get to red. Okay, we'll give it another minute here to see if anybody else has any. Yeah, I echo that, Julie. Great way of saying it. Somebody who has my number, text me Lusher's number. I can't find it right now, so I can call him, okay?
All right, so over the next few days, watch out for changes. If you have questions or anything's unclear, please shoot me an email so that we can clarify anything. And if you have questions, tune in next Tuesday and we can address any questions that come up. Please stay safe out there. Please try to stay safe out there, protect each other, wear your PPE. We know it's hot, and thanks for all that you're doing. Have a good day.
Stay safe.